welcome in Rotterdam. My name is Koen Niemon. I'm a cardiologist associated with the departments of cardiology and radiology at the Erasmus Medical Center in the Netherlands. Today we will show you how cardiac CT and myocardial perfusion imaging can be used in the workup of patients with stable chest pain. Well, in the past we mostly used stress tests for non-invasive evaluation of patients with chest pain. Coronary CT angiography allows for non-invasive exclusion of coronary artery disease. While on one hand CT angiography is a very efficient technique, it does not tell us whether the lesions that we find are hemodynamically significant. For that reason, myocardial perfusion imaging offers an alternative that we can add to the CT angiography in case we find abnormalities to tell us which of the lesions are important and which of the lesions are not. At first, dynamic myocardial perfusion imaging may seem like a complex examination. Today we use a third-generation dual-source CT, the Somatom 4 scanner. With this scanner we have a faster rotation and also longer coverage, which makes the examination a little bit more easy. During this demonstration we will show you some tricks and recommendations how to perform the examination in an effective, good manner. For dynamic myocardial perfusion imaging, patient preparation is essential. The better the patient cooperates, the better the scan results will be. Before the scan, we explain the procedure and the sensations the patient will experience in detail. This will avoid any surprises during the examination. For the adenosine to work properly, we ask the patient not to drink any coffee or other caffeine-containing substances. Before the scan, we will practice the 30 seconds breath hold and go through the commands that she will hear during the scan, like breathing in, breathing out, and hold your breath. Adenosine will be given as a stress agent. The effects of this agent may be warm sensation and some pressure on the chest. If we inform the patients beforehand about these sensations, the patient will be more relaxed and will be better able to cooperate during the examination. When the patient is ready, we prepare the scanner for the myocardial perfusion scan. During such a myocardial perfusion scan, we use the dedicated heart perfusion protocol. For this protocol, we acquire a sequence of images that are low dose, cover the entire myocardium, including the aorta, for the arterial input function. You need to select the heart volume perfusion CT protocol. Individual settings can be adjusted according to the patient characteristics. We start off with a topogram and often a calcium scan. If the calcium scan is acquired during systole, we can use it to plan the subsequent scans. In addition, we will also do a test bolus. This allows us to plan the bolus during the perfusion scan. Now it's time to start the perfusion scan. With the instructions practiced earlier, the patient is able to hold her breath. We inject the contrast and start the scan. The scan will take approximately 30 seconds. The images are acquired during systole. During systole, the myocardium is thicker and more compact, which makes perfusion images better to interpret. In addition, because the cavity is smaller, there will be less contrast and also less beam hardening artifacts on the images. Finally, during a very long scan, the heart rate may change, and in that case, the end systolic images are more consistent over time. After reconstruction, the images are now ready for post-processing.
Okay, so after the scanning process, we have to load our data into the single-via post-processing software to prepare the images for reporting. And then we have to follow a couple of steps. One of the first steps is that we have to check the data for motion. So we scroll through time and see how the data is quality-wise. If we desire, we can delete data points and we can add a motion correction algorithm by the computer. And after the motion correction algorithm, we have to check whether we are satisfied with the result. And if we're satisfied with the result, we go on to the next step, which is the myocardial segmentation. It's automatically done by the software. There's a region of interest around the myocardium of the left ventricle. If needed, we can do manual adjustments and small corrections. And if the segmentation is correct, then we can go on to the following step, which is vessel definition. In vessel definition, there are two areas marked in the aorta, one in the cranial acquisition position and one in the caudal acquisition position. We have to check if the software done this region of areas correctly, and then we have to check whether the time attenuation curve of the arterial input function is nice and smooth. Another thing we have to check is if the threshold only holds contrast and doesn't include the myocardium. And if that's correct, then we can go on to the next and final step. And the last one is the calculation of the perfusion maps. In this case, we can see the perfusion displayed with a color overlay. Red and yellow are high flow values, and blue and green are lower flow values. If needed, we can change the orientation. For instance, we can decide to go and look at the image in short action view. And this completes the post-processing step, and now we can send the images to the doctor for the final reporting.
So what we saw in this case on the CT angiogram was that both the LAD over here, but also the right coronary artery had significant lesions, as you can see over here in the right coronary artery. So the question was whether the perfusion defects would show up for either of these territories. So here we have the left anterior wall, which shows lower MBF, while if we compare that to the right coronary artery inferior wall, we can see that there is hardly any ischemia to be seen. This suggests that the LAD lesion is more hemodynamically significant compared to the right coronary artery lesion, and if a revascularization would be considered, the LAD would be the most likely candidate for revascularization. At the Erasmus Medical Center, dynamic myocardial perfusion imaging has become an important part of the comprehensive cardiac CT protocol for patients with chest pain. The entire examination can be performed in 30 minutes, and the total radiation dose for the perfusion imaging can be less than 5 millisieverts, as in this case. Now, to have both anatomical and functional information in the same patient allows you to assess the hemodynamic significance of coronary stenosis and make better management decisions for patients.